Yep. All right. So mastering medications for podiatry. So I did one on Naproxen, which is obviously an NSAID. Just a little bit about what we're going to go through today. Probably just a piece of gratitude for Steph in putting this template together because it's probably it's definitely the first time I've used it in its full entirety. And yeah, it was just like so easy to use. All your prompts and everything were like to the point. Even the little graphics were pretty cute. And yeah, big kudos for Steph putting the template together. Made it a breeze. So introduction. Dick is my patient, presents with right foot pain over the last 1 to 2 months. He describes it worse at the end of a day with increased walking. He recalls maybe dropping something on his foot about 1 to 2 months ago. And probably the other important thing about Dick is that he's had a recent heart episode, and that subsequent to that, he's now on a research program for an anti-inflammatory injection. So he's unsure if he's getting the placebo or if he's actually getting the proper anti-inflammatory medication, which I'll go to in a sec. He's on it for 2 years and he's had 2 initial injections and then they're once a month over a 2 year period. He's a bus driver for work. So he works at the local high school Christian college, but he's currently off work due to his recovery from the heart episode. His pain is worse in certain footwear. So his Merrill slip-ons are old and loose and they seem to give him a little bit of trouble, and he just wears Crocs around the house. He's normally pretty active, roughly sort of 10,000 steps a day. He enjoys yoga once, twice a week. He swims regularly, and has currently been building up his daily walks after his heart episode. He's currently doing anywhere between sort of a quick lap around the block to up to 2Ks. He pretty sure he goes to Keys or one of the gyms here in Ocean Grove, and he has difficulty with balancing exercises in rehab, and he describes like quite a sharp pain with any stability type exercises. And just another mention of, or another thing of note would be nerve issues of his foot from a pair of slip-on boots. He's also had a couple of calf injuries and some Haglund's deformities as well. Oh, what? You can't see those?
I think if you exit it and refresh it, they'll pop up.
All right, let's try that.
And then like just like if you click the refresh the actual URL normally sorts it out.
All right. Thank you, kindly. So just yeah, based on his history, just thought it'd be worthwhile just going through a little bit more about his heart episode. So an AMI or a heart attack is the main cause of a cardiogenic shock and is associated with high mortality. It's kind of two different classes. So a STEMI or a non-STEMI elevation according to the patient's ECG. So he's had a number of ECGs. Pathophysiology can vary a fair bit. And there's pretty much the non-STEMI ones are a little bit more to do with the coronary artery and coronary artery disease, which overall has a similar prevalence, a similar long-term outcomes. And the non-STEMI has just varied or more difficult long-term prognosis. So just a subtle variation between a STEMI and a non-STEMI with his, just in terms of his recovery. So the medication, so I prescribed him Naproxen. Obviously comes in a few different brand names as well. It's a class of rheumatological drugs or non-steroidal anti-inflammatories, and specifically it's a non-selective NSAID. It has a half-life of between 12 to 15 hours, and generally the oral doses are 2 per day, but then it also comes in controlled release products, which is 1 per day. So yeah, different formulations can include tablets of 250 and 500 milligrams, which would be 2 per day, and then longer controlled release tablets of 750 and 1,000 milligrams. There is also an oral suspension or a naproxen suspension that's available as well. Mode of action. So yeah, NSAIDs inhibit the synthesis of prostaglandins. Hopefully you know that it presents as either COX-1 or COX-2. So the COX-1 impair the gastric cytoprotein and antiplatelet effects, and then the COX-2 are anti-inflammatory and analgesic. Most NSAIDs are non-selective, and in this case, naproxen is a non-selective NSAID, and we obviously know a lot about the COXIBs, which are selective NSAIDs. And in particular, naproxen's helpful for us. Actually, I might explain that a bit later. We're going to go through...
NSAIDs, also known as non-steroidal anti-inflammatory drugs, are a group of drugs that help inhibit inflammation, pain, and fever. And they work by inhibiting the synthesis of a really important group of chemicals called prostanoids, or more specifically, prostaglandins. Now, these prostaglandins are synthesized by an enzyme called COX. There's 2 types, COX-1 and COX-2, and the NSAIDs inhibit these COX enzymes. Now, the prostaglandins produced by COX-1, they are always being activated, and they play really important housekeeping roles. So, for example, these prostaglandins help maintain our gastric mucosa, so stop the stomach from digesting itself. It helps maintain renal perfusion, so it tells the blood vessels going to the kidneys to remain dilated so more blood can get in to be filtered, and also helps in the production of platelets. Now, the prostaglandins produced by COX-2, they're not always activated, they're inducible. They need to be activated, and they're activated by tissue damage. And when this happens, the prostaglandins that are produced play an important role in promoting inflammation, pain, fever, and inhibiting platelets. So now when we take a look at the different types of NSAIDs, what you'll find is that they all inhibit COX-2, but their clinical relevance depends on how much they inhibit COX-1. So aspirin, mostly COX-1 inhibitor, but also inhibits COX-2. Ibuprofen, diclofenac, and naproxen all inhibit both around about the same. And then finally, the COXIBs are COX-2 specific inhibitors. And so now you can take a look and see what are the possible side effects of each of these types of NSAIDs. These ones predominantly obviously can play a role in having some issue with our gastric mucosa, increasing the likelihood of bleeds and ulcers. Can also have an issue here with renal perfusion. So people with certain kidney disorders, they may experience acute kidney injury. And also stopping platelet production, one of the reasons why low-dose aspirin is used for people who are at risk for cardiovascular disease. Also, the COXIBs, because they inhibit COX-2, really good as anti-inflammatories, analgesics, antipyretics, but also increase in the production of platelets, and this might be an issue with people at risk of cardiovascular disease.
So I just thought, also very timely, I could grab a quick bite to eat, but I thought he explained it a hell of a lot better than what I could. So yeah. Indications, any rheumatological condition, so rheumatoid arthritis, osteoarthritis, ankylosing spondylitis, juvenile idiopathic arthritis, and any pain due to inflammation. Probably the main things that we're going to be using it for are any musculoskeletal inflammatory conditions. We're not likely to be prescribing it for rheumatoid arthritis. That's going to be taken care of by the GP or rheumatologist. Same for osteoarthritis. So I guess, most of it is going to be just generalized musculoskeletal pain that we're going to be trying to use it for. So the dosage. So we've got a maximum of 1,250 milligrams per day. So typically the patient would take twice daily dosage of a 250 to 500 milligram tablet, or a once daily dosage of a 750 or 1,000 milligram tablet. Dosing equivalent for a child obviously changes. It's probably all the relevant information for the dosage of naproxen. Fairly, like there's not a heap of tablets, so it's fairly simple or fairly easy, and hopefully, yeah, pretty straightforward with the dosage. Precautions, yeah, pretty typical for all our NSAIDs, any dehydration, which can cause acute renal failure. So just making sure that, yeah, the patient's well hydrated and able to, I guess, yeah, flush it through their system. Asthma, increase the risk of bronchospasm, any coagulation disorders. So obviously with their antiplatelet effect, there's an increased risk of bleeding. And then probably the relevant one, cardiovascular or cerebrovascular. So where possible, use cautiously in cardiovascular disease, as there's an increased risk of cardiovascular conditions, in particular MI and stroke. Yeah, gastrointestinal, contraindicated in people with active peptic ulcers, disease, or GI bleeding. Hopefully we're all aware of that. Yeah, can play a role with, yeah, a lot of GI disruption. It's probably one of the main things that we're going to be asking our patients about, if they're on them or if they've had previous history of. Any hypersensitivity reactions. So yeah, if they've had any asthma or yeah, any immediate reaction to NSAIDs in the past, we won't be prescribing for that. And obviously the impact on the kidney and liver, so contraindicated in any severe hepatic or kidney conditions. Post-surgery, so yeah, in particular consideration of dehydration and any renal conditions post-surgery, in increased risk of cardiovascular events with both NSAIDs, and increased risk of bleeding. Elderly, essentially just monitored for any adverse effects, in particular heart failure, gastrointestinal ulceration, and renal impairment. That type of population is obviously just at an increased risk of, yeah, a lot of polypharmacy. So they're often on a number of medications, as well as, yeah, a number of other comorbidities. NSAIDs may impair fertility by preventing delayed ovulation. So obviously not relevant in this case, but particularly for women. Also checked out the pregnancy and breastfeeding guidelines. So in the first trimester has not been associated with increased risk of congenital malformations. However, naproxen has been associated with an increased risk of cardiovascular defects. So one thing to note, yeah, particularly for pregnant or breastfeeding women, maybe naproxen isn't our go. And just in general, looking at alternatives for, yeah, pain and yeah, obviously any of the effects that we're after out of the anti-inflammatory when people are pregnant. In terms of breastfeeding, so there is a small amount excreted into breast milk, but they're unlikely to cause any harm to the infant. So yeah, otherwise considered safe to use once not pregnant and currently breastfeeding. Thanks, Henry. Appreciate that. Thank you. So yeah, the things that we'll be asking our patients about when they're on it or when we're reviewing with them, yeah, any GI, so gastrointestinal considerations. Have they had an upset stomach? Are they not quite feeling a little bit right? Any diarrhea, headache, dizziness, anything, yeah, postural hypertension, anything that's going to affect, I guess, their overall, yeah, cardiovascular system. Salt and fluid retention and increased heart rate or hypertension. Infrequent, yeah, heart failure, any of the renal and kidney type things. And then, yeah, a few rare cases of some other stuff. But we're going to be mostly talking to our clients about, yeah, a lot of the GI upset, a lot of the, I guess, cardiovascular symptoms that they might be presenting with. Just in terms of, I guess, counselling, so ideally take it with or shortly after food for naproxen. Don't crush or chew it, take it as a whole tablet. And then, yeah, just don't take it when they're dehydrated so that they're able to, yeah, their renal system, their kidney system's able to take care of it. The controlled release products can be taken at night to relieve nocturnal and morning symptoms. So just if you are prescribing a I guess, slow release product that, yeah, nighttime might be best just to provide most coverage throughout the day. So I looked through MIMS and I guess looked at other medication that he was on. Overall, yeah, the aspirin was probably the main one. So he was taking some low dose aspirin with the GP following his condition. And obviously provides an additive toxicity with aspirin, as it's also obviously an NSAID used for different reasons. So that was probably our main precaution with prescribing naproxen, and in particular why we consulted with the GP in this instance. So just with the article review that I sent through during the week, so overall NSAIDs are likely to increase the risk of cardiovascular events. They do so based on COX-2 selectivity, with greater affinity for COX-2 impairing greater risk. Therefore, yeah, naproxen has low COX-2 selectivity. I know that video said that it was roughly 50-50, but a lot of the recent research, and in particular this article, demonstrated that it has greater selectivity for COX-1 inhibition, imparting a consistent and demonstrable favorable thromboembolic and overall cardiovascular safety profile among the most commonly used non-aspirin NSAIDs. So just in general, for our clients, if they do have cardiovascular risk and we are needing to prescribe an anti-inflammatory, then naproxen is most likely going to be our most safe and effective. And this kind of demonstrates that. So it's often categorized as non-selective or selective. They inhibit both, but yeah, effectively naproxen sits fairly well in terms of a relative risk in comparison to our COX-IBs, as well as some of our other non-selective NSAIDs. So naproxen binds reversibly to COX-1 and COX-2 to exert its effects, but it has an increased selectivity for COX-1 inhibition. Naproxen reaches peak plasma concentrations between 2 and 4 hours and has a half-life of, yeah, sort of 12 to 15, 12 to 17 hours. It's a highly effective analgesic, and its long half-life provides consistent blood levels and efficacy, making it a choice comparator in many clinical trials. And I guess, yeah, the dosage is suitable and relevant for a lot of our population with either single dosage or twice daily dosage. So just back to Dick. So Dick, he was my 63-year-old bus driver. He presented with right lateral foot pain and ankle discomfort, exacerbated by ladder use, golf activities, and certain gym exercises, and it's primarily located on the lateral border of the foot with some arch involvement. And he describes that spot on the outside of the foot. I'm pretty sure he'll talking to his stylo process, and he feels it a little bit underneath his arch as well. Pain worths with some stretching and weight-bearing activities. He's currently on some Panadol, osteo, aspirin, and a few of the other medications we saw before. So this was my prescription for Dick. So we prescribed him a controlled release, 750 milligram naproxen. He was to take 1 tablet once a day for 5 days only, followed by as required for pain for no more than 5 consecutive days. It comes in a box of 28, which is why I prescribe 28, just trying to limit the chemist or pharmacy having to split the box. So just further discussion. So tenderness on the palpation of the right fifth metatarsal and peroneal tendons. He had a CT which showed essentially no acute fracture or a stress response. That was referred by his GP, that there was a little bit of mild degenerative change of his fifth metatarsal base, and that if it was giving him grief, that we would consider an MRI. And there was an increased weight bearing and pronation of his right foot during gait. So our assessment provided, peroneal tendinopathy of his right foot, likely secondary to deconditioning post-recovery from his heart condition, as well as a change in footwear. He went from wearing, I guess, boots and being fairly active to mainly just shuffling around the house in an old pair of Crocs and an old pair of like Merrell sandals. And obviously got fairly deconditioned by being, very sedentary throughout his recovery. And there was no evidence of any sort of differential diagnosis, so no acute fracture, no sort of lateral or plantar fasciitis. We're fairly confident of what it was. what we provided for him. So other than obviously the medication, we got him to modify his load, so avoid walking on cambered surfaces. He lives in Ocean Grove and enjoys a walk down the beach, so we just tried to limit that, using the footpaths instead. We changed his footwear, so we updated his mineral shoes for better support, and he came in on a CDM and was an absolute tight ass. So I actually prescribed a single formthotic for his right foot with a valgus wedge. He didn't want to buy both formthotics. It's an absolute low point in my career, but Dick was a very hard man to try and bargain with. We prescribed some exercises, so we gave him some foot intrinsic strengthening, and some perineal strengthening with a band. And during our consultations, provided some sort of FMT, some massage to his lateral foot and perineals. We sort of reviewed every 1 to 2 weeks. Once again, very difficult man to get back in for reviews. He's not the most compliant, 63-year-old male, where we performed, further manual therapy, and exercise progressions. And we discussed ongoing management, that it would take, some time over the next sort of 1 to 2 months before it would settle down and we wouldn't be able to see him again. We also progressed to the point where he was still getting symptoms. So he trialed a couple of sort of 5-day blocks of the anti-inflammatories, with good effect. And so rather than just continually prescribing him an anti-inflammatory, we thought it would be a lot safer for him to undergo a localized cortisone injection, I guess surrounding the perineal tendon insertion. And so, following discussion with him, we agreed that would be of benefit. So pretty much I've got the stylo process in view here with the perineal tendons coming down and attaching on. And pretty much I lined it up in plane and we injected out of plane, just trying to get into the little cavity behind the tendon where the stylo process is. I figured that wasn't a bad spot to try and put it. There's potentially less adipose waste if it's more deep or plantar. And obviously I didn't want to inject into the tendon. So hopefully in this area here, I think that's my needle tip just in there, somewhere in the fluid going into this section here. And overall he tolerated the injection well, and he actually didn't come back for his review because he said it felt good and he didn't want to come back. So definitely not my finest treatment journey. So there's obviously risks associated with NSAIDs, and in this case it was of high risk for cardiovascular events due to his previous heart attack. And so what I did was I called his GP, and pretty much the GP said, just pick your poison. He was okay with a short prescription of Naproxen. And at that time I did the search for all the other medications, which indicated that there was, the main interaction with aspirin. So he said the GP just took him off the aspirin at the same time as the Naproxen, so he just wasn't double dosing on the anti-inflammatories, and that, Naproxen was likely to provide more anti-inflammatory and pain relief for him. And so, he went off his aspirin. He took 5 days of the Naproxen, and got confirmation from the GP that he was safe and happy for me to prescribe it, and just educated Dick on just monitoring for symptoms. So any lightheadedness, any postural hypertension that he might be experiencing, any gastrointestinal side effects, and just in general, if he was not quite feeling right, to stop using the medication immediately. So just in summary of the case, probably the main things for me were just the selective use of NSAIDs, so matching the profile of the drug with any comorbidities and medications of the patient, and above all else, do no harm. I think it was a little bit of a risk to be able to prescribe this so soon after him having a heart attack, but I think probably the thing that eased my mind a little bit was just communicating with his GP, who is local here in Ocean Grove, and that it was in relative alignment to the registration standards where we weren't prescribing an ongoing dose or ongoing prescription for it, and that it was within the guidelines being less than a week of prescription. And that's all I had for my presentation. Happy to take any questions.
I have a question, Ollie.
What do you got?
At the start, did you say he's being involved in a clinical trial?
Yes.
Yeah,
Oh, yeah.
Yeah. So in that case, do you just assume they're taking that medicine? Because you probably just can't find out, like, if it's like.
Yeah, I couldn't find out if it was the placebo or the actual anti-inflammatory drug. I'm fairly sure it's not the anti-inflammatory drug because he was still obviously having pain and symptoms and having these inflammatory type conditions. I had to write a letter to the clinical trial just saying of what we prescribed to him, just so that they were aware of it, and just gave essentially clinical reasoning as to why we needed to do it, that he was having localized inflammatory reactive tendinopathy of his perineals, and that we thought it would be suitable for his level of function to be able to use the medication. So yeah, I had to provide a letter, but we will never know, and we're not able to find out whether he was actually on the medication or on the anti-inflammatory injection or the placebo. Does that answer your question?
Yeah. I just guess, like, do you just, in those cases, if you've got a patient that's involved in a clinical trial, do you just assume they are when you're sort of doing that checking for interactions? Because there really isn't a way to find out.
Yeah, and like I didn't know what to look up. Like I didn't know what the medication was. He wasn't able to provide me the like what the actual intended drug was. And
so
so
he didn't even know what he was
didn't even know. So yeah, it was a bit of an unknown.
Did you consider just going straight to a cortisone injection?
We did. He wasn't that keen on it. He wanted to try the anti-inflammatories first. He was pretty stubborn. The cost, he wasn't that rapt about the cost of a cortisone injection. And yeah, he just wanted to try the anti-inflammatories first. We actually held off on this. We tried a lot of the manual therapy, deloading, insole, tried some shockwave through the perineal as well. I didn't mention that, but tried some shockwave through the perineal and through his lateral leg, and we probably had maybe 3 or 4 sessions sort of a week or 2 apart, and avoided any anti-inflammatories for that period of time. We discussed it at the start, but because he was on his clinical trial, we decided not to do it. And then it kind of got to the point where he was fed up with it. He'd had enough, and that he was keen to try it. So obviously, contacted the GP. He gave the okay, and we prescribed it after that. And so, I guess there was a fair bit of delay in him receiving it. Potentially in hindsight, you might not bother. And if, he was wrapped with the cortisone after he had it, so you'd probably just say, suck it up, and it's likely to provide benefit. Not in those terms, obviously.
Did you ever hear back from the trial?
No, I sent my detailed report off, and then I had heard nothing back. So, not that it's that detailed. This is take his name out. So I just said that, he presented with right peroneus brevis enthesopathy, that we prescribed a prescription for him of naproxen on that date, and then that we provided an injection. After he had a therapeutic benefit to that, we provided an injection. We also mixed it with glucose rather than local anesthetic because he drove to and from, and he wanted to go to work afterwards. So I just needed something else to be able to mix it with. And glucose was the only thing that I had on hand. And yeah, never heard back from them. Maybe it was the glucose, Chris.
Who knows?
We'll never know.
Maybe it was placebo.
Yeah, yeah.
I mean, technically, those two things are canceling each other out. So
One's pro-inflammatory, one's anti-inflammatory. But
it worked. That's all we need to know.
yeah, it worked so much he didn't want to come see me again.
But you'll probably be the first person he calls if something else happens.
Hope not. He was a pain.
Great
Yeah.
present.
Yeah, awesome Prezzo. It was interesting reading the article. I don't know if anyone else noticed it about there was a section in there about like the acidity of like different anti-inflammatories and like how that can affect their accumulation in sources of inflammation. Did anyone else find that in the article, or did you? So it was like there's a little section like, and it was saying how like the acidity of NSAIDs that are more acidic will actually bind to sources of inflammation more than those that are non-acidic, which will provide like a more systemic result. And it was just one thing when I was reading it, I was like, oh, it's probably something I need to, consider naproxen more for, because that Nurofen, Voltaren, like if we're dealing with some really localized specific sources of inflammation, like potentially they're actually going to be concentrate more at those areas that we're trying to treat versus some of the more like celecoxib, meloxicam, more those selective inhibitors. Just thinking from like a safety profile point of view, yeah, like it's just another good reason why naproxen would have been a good choice in your case, I thought.
I mean, is that why diclofenac has a higher anti-inflammatory? I guess, yeah, why it works so well as an anti-inflammatory is maybe its acidity.
Yeah, well, that's what I thought. I was like, I thought it maybe explains why Voltaren does tend to be a bit of a go-to for like MSK conditions, in people that kind of don't have any other particular issues.
Yeah.
Yeah, and probably as well, if you look at the inverse, something like someone who's got rheumatoid or something where it's a bit more systemic, they're on that low dose Celebrex or like I'm sure there's lots of factors as to why they prescribed it, but
if they've got multiple sites or multiple joints and they need more systemic coverage, then the coxibs are helpful.
Mm.
We'll pick up, Chris.
So I think you picked the article. I just thought it was a good read.
Any other questions? Sorry again, it didn't quite live up to Chris's presentation, but hopefully you got something out of it. And hopefully naproxen is your NSAID of choice for any future cardiovascular patients you might have. And yeah, definitely worth, if you can, getting a hold of the GP if you're going to be prescribing it when people are at risk. They're probably my two takeaways.
in a month, Nelson's presenting, and his is actually looking at NSAIDs versus colchicine for gout as well. So it'll be interesting, like still diving into NSAIDs, but seeing what comes out there as well.
Good one. Go and enjoy your Friday. See you over the weekend. Have a good weekend.
Thanks, Ollie.
See you guys.
No worries.